So the next speaker that I'd like to invite to present is, and it's an absolute pleasure to invite him, is Professor Sebastian Wicha. He's a professor of clinical pharmacy, and he's got a research group at the University of Hamburg in Germany. He's had that group since 2017. He is a pharmacist by training. He holds a PhD in clinical pharmacy from Freie Universität in Berlin, Germany, and a full professorship since 2021. He was a postdoctoral researcher with the Pharmacometrics Research Group at Uppsala University in Sweden from 2015 to 2017, and published over 90 peer-reviewed papers. His research group aims to improve and individualize drug therapy by means of PK/PD and pharmacometric techniques, with a special focus on anti-infectives. His group specializes in bioanalysis, pharmacometric data analysis, and develops open access web-based software to foster model-informed precision dosing, TDMx, being the software that's we're talking about there. He's an associate editor at the International Journal of Antimicrobial Agents, IJAA, and served as president from 2020 to 2022 of the International Society of Anti-Infective Pharmacology, ISAT. And since 2019, he's been an education officer of the PK/PD study group of the European Society of Clinical Microbiology and Infectious Diseases. He's an external expert in pharmacometrics for the German Federal Institute for Drugs and Medical Devices and European Medicines Agency. So he's got vast experience. I've certainly learned a lot from reading Sebastian's papers through the years. And without any further delay, I'd like him to start his presentation. Thank you.
Os, thank you very much for the kind introduction and also for the invitation. So I'll, in the next 20 minutes, share a bit about our experience with using but also developing TDMx as an academically driven open access model-informed precision dosing software. I have a few disclosures that I'm showing here for a few seconds, and then I will move on. So we already had a very nice presentation from the previous speaker introducing some of the underlying concepts. I want to add upon this a little bit because dosing software essentially uses pharmacometric models in the background. And a pharmacometric model is usually developed based upon a certain population. So you might recognize this population here from the television. And then if you study the behavior of a drug in this population, a population pharmacokinetic model or a pharmacometric model is usually consisting of several components. For example, a structural model defining whether this is a 1, 2, 3 compartment model. Then there's a pharmacostatistical submodel where different variabilities are captured. And also very often we find a covariate submodel where, for instance, body weight, renal function, age, or whatsoever was found as a covariate being predictive of the pharmacokinetics. And now, when you like to use such a model for model-informed precision dosing, you use dosing software to infer about an individual patient that should stem from this population. And please keep that in mind. That is really important. We will come back to that. So as also indicated by the previous speaker, the population pharmacokinetic model and the patient, they should be in a way similar. So that patient should really stem from that population. And yeah, we use dosing software for that purpose. And luckily, we have a lot of choices. We have many very nice dosing softwares available. This is from a review from a few years ago. This is not an exhaustive list. There are more. And we also develop a software called TDMx. And you see a screenshot of this software in this slide. It is provided as an educational tool, open access, so you can start it directly in the web browser. And then once you open one of the drug applications, it looks like this. So on the left-hand side, you can enter patient data, laboratory data, also a dosing record if that was already available. And then on the right-hand side, all the entries that are made are directly visualized. And then there's also a table down here where more information on the PK and also AUC, MIC is provided. And here you can nicely see the difference between a priori and a posteriori. Here it's called population and individual. So here in this bluish curve, you see the population prediction with higher uncertainty. And then once TDM samples are available, you get this orange curve, and you see how the uncertainty in the prediction can be narrowed down. And then here on that left-hand side, under dose optimization, you could ask the software, you know, if I want to add a dose for a certain AUC over MIC ratio that should be attained, that can be then calculated there. So if you now compare this model-informed precision dosing approach with a conventional TDM approach, there are several advantages that come with the MIPD approach. So you can actually already calculate a likely effective first dose just from the patient covariates. That comes with some uncertainty, but you still can consider much more variables than just with a dosing table. And you've seen that in the previous slide. You don't need to wait for steady state. Actually, after the first or the second dose, you can already draw a TDM sample and provide that to the software, which means you can be more precise more early on, which is very important for anti-infectives to get the dose right as early as possible. Then technically, you don't need to use a trough sample. Any timed sample can be processed. We'll come back to that a little bit later. And then from that single sample, you can derive the full PK curve, as you have seen before, and then use this to maximize the probability of target attainment. So that sounds very appealing. But as a research group, we, of course, wanted to study also the potential caveats. And I already introduced that. Which population model shall we use? I will show some research in that direction. When to sample? I mean, any time sample works, but are some samples still more informative than other ones? How robust is the process? And how do I deal with unstable patients where the PK deteriorates over time, which can happen in critically ill patients? So these points will be covered in this presentation, and we will first start with the topic of which models shall we use. And there, that venture started in 2019 when we developed the vancomycin application. And in fact, we realized that you have a lot of choice. We had now there are more than 40 published population pharmacokinetic models available for vancomycin. And for sure, you cannot just pick any model. You should really make sure that you choose the right model. And these are just 3 examples here where we evaluated models for vancomycin in different settings. So in general ward and ICU patients, where patients were dosed intermittently, and also here a general ward cohort where vancomycin was dosed continuously. I'm showing you now the first example here. So on the x-axis, you have the different models. Then here in the upper panel, you have the relative bias of the prediction and the relative RMSE, so the imprecision of the prediction. And then here, different types of information were provided to these models. Covariates only, which is our a priori case. And then, TDM data, less TDM data, more TDM data. I'm not going into the details now, but as you can probably see, the predictive performance was very, very heterogeneous. Some models performed really well. Others showed very, imprecise and inaccurate predictions. Sometimes we could directly tell why that was happening. For instance, if the population was very different from our general ward population, for instance, if that were Burns patients or something like that, or sometimes we could also see that the sampling schedule that was used to derive the population pharmacokinetic model in the first place was not optimal, but sometimes it was not clear why some models performed better than others. And here in that exercise, we found one model that performed best, which was the model from Goti et al., which is also now available in many dosing softwares for vancomycin. Now you might ask yourself, are these differences in the predictive performance relevant? Here, this is a very nice paper from our colleagues in Sydney, and they looked at 3 models that actually show a good predictive performance. And as you can see, the agreement is only up to 70%. So these differences do matter, and you might classify one patient as being therapeutic within the range here for vancomycin between 400 and 600, and not being therapeutic, also depending on the model you use. So here, how to how to live with that, or how to overcome these problems, I would always recommend to assess the AUC using different models, kind of a risk assessment. And also, if you optimize for the AUC, optimize maybe for 500, so that you are really in the middle of the therapeutic range, which means you have a higher chance that you have agreement across the different models. Now I want to show you another example, and that is also still vancomycin, also still the general wart cohort, but now vancomycin was infused as a continuous infusion. And now let's see, that was the GOTI model that won the comparison before. And you see now this is a model that has some bias. So once you change the mode of administration, another model actually might be the best model. And here it were 2 models, the model from Collin et al. And Okada et al., which performed better here. And this is certainly something that makes the use of model-informed precision dosing software a little bit difficult. If once you change the mode of administration, actually another model might perform better. And there we step back and try to think a bit critically, what can we do actually from our research perspective to help finding the best model for the individual patient. And that was a PhD project by David Uster, where we came up with an automated model selection or model averaging algorithm. How does this work? So you have your patient, and then instead of estimating a single population PK model, you estimate a number of candidate models and have a number of a posteriori predictions as shown here. And then depending on how well each of the models fits the individual PK data, these individual model fittings are weighted. So the model that has a better fit gets a higher weight, and the model that has a poor fit gets a very low weight. And that weighting is done based upon objective function value or model fit. And then after that estimation step, you do the weighting, and then you can do 2 things. You can do an averaging, which is this black line here. So you average the predictions using these weights. And the other approach would be to do a selection. So the winner takes it all. The model with the highest weight is selected, and the other models are discarded. And to set this approach up, we went back to our model repository that we generated for vancomycin, and we really try to select models that are different. You can see these come from rather different populations, and they also show a different PK profile. So this profile here is generated in steady state using the same dose, the same patient covariates a priori here, and you can really see they give you very different individual predictions here. And now the question was if we can use these models, these candidate models, in a data set, whether these can improve the predictive performance if they are used together. And indeed, that worked quite nicely. So you see here again different parts of the data set that were supplied to this new algorithm. You see here the bias, the RMSE, see here the performance of the individual models, and then here the averaging and selection. So the averaging is usually a little bit better than the selection. And then here we also compare to the GOTI model, which in this heterogeneous data set also was not the overall best model. So And that is insofar nice because there the user doesn't have to find the best model for a patient, him or herself, but the algorithm actually can work this out with a number of candidate models. And I'm not showing this here, but I want to mention it. We did this now with 3 or 4 other drugs, and we get the same answer that when you use model averaging and you use a set of models together, you usually can improve the predictive performance and ease the model selection on a patient level. So that brings me to a point that I usually say MIPD is not a click and forget solution. You should really always inspect the individual patient data and the model fit. So for example, here, this is a patient from one of our data sets, which is a little bit obese here. And we see here, if we would use the GOTI model, here we have over prediction, here we have under prediction. So this model is not optimally fitting the patient data. And then here, if we would choose the Adana model, which is a model that was specifically developed in obese patients, we get a much better model fit. And in the software, you can just reach that by clicking auto select, and then you will get the best model for this individual patient. The next point I want to touch upon a little bit is optimal sampling time points. In clinical practice, it is really the trough sample that is mostly used. But is it also the most informative one? At least here for vancomycin to come up with an AUC, that is not the case. So you see here the bias and the imprecision, and this is the trough, particularly in the early phase, for the first dose, you get a much higher imprecision of the estimated AUC if you take the trough concentration. It's a little bit better in steady state, but still, it's rather the early samples, 2 hours up to 6 hours, that gives us a better estimate of the AUC when using a single sample. If we use 2 samples, this curve becomes much more flat. So which means there you can do less wrong, but which makes sense. You provide a lot more information to the models. So with 2 samples, it doesn't matter so much. I just want to highlight here the EQA, that's the equation-based approach, where you take 2 samples. That is also inferior to using a model-based approach. So you have some bias and some imprecision also, which is higher than using the model-based approach, because you make a lot of assumptions when you just do a log linear regression. And that was a simulation study, but actually this is in line with some clinical studies that were performed as well, where optimal sampling time points were evaluated. So here for topramycin to get an AUC from a single sample, or for vancomycin where they wanted to get the AUC from a single sample. And there were also the early samples, and that was really a richly sampled clinical data set. So less patients than in our simulation study, obviously, but they had the full AUC from the trapezoidal rule, and then could blind some of the data points to the models and compare to the true AUC. So the paradigm of the trough at least should be questioned from a scientific perspective, and early samples to get the AUC of aminoglycosides and vancomycin are preferable. For MIPD, another important point is also that garbage in equals garbage out. So if you have a bad documentation of dosing time, administered dose, infusion length, timing of the TDM sample, that will also affect the precision of the doses that you calculate from the models. So if you want to do precision dosing, you should do a precision documentation as well. And here are just 3 papers, 2 from other colleagues and 1 from us, where we looked a bit into documentation issues and how can they affect the predictive performance. But I think the future is bright and looks very interesting. And here I'm referring to those biosensors. I mean, for diabetes care, these are already standard of care, very frequently used. But for TDM, this is still under active development, but I've been promising data so that you could have a variable sensor, and that would send the concentration time data in real time to, for instance, the electronic health record, or to even an infusion pump. So this could become a closed loop. And I think we will see that in the 20s, that this will go hand in hand with chromatography, and maybe at some point, I'm not sure about this prediction here when that will happen, but I think we will see that. That we will have this really as a closed loop, and we don't have to rely on the more time-consuming chromatography techniques. So in the last few minutes, I want to focus a bit on unstable patients, so patients where the pharmacokinetics changes over time. So in stable patients, it is well known that more TDM data also improves the predictive performance. So the more you sample, the better your prediction will get. And I'm just zooming in here for the GOTI model in a general ward patient. In the general ward population, this was also true. The imprecision actually goes down as you add more TDM data to the software. But for unstable patients, this is not necessarily true. And this is from our colleagues in the Netherlands, who looked at that phenomenon in more than 400 unstable ICU patients. And they looked at the conventional MAP estimation, which is the MAP estimation that is used in most dosing softwares. And you can see that when you add more information, actually the predictive performance got worse. And they developed a nice algorithm, a so-called adaptive map, where the prior is adjusted in the course of therapy. And with that algorithm, they could improve the predictive performance. So when we saw that, we also wanted to check how does that look like in our data set, or in our data sets. So this is work that was led by our colleagues in Munich around Uwe Liebchen. And here, even those were unstable, critically ill patients, the picture is diverse. So actually, in some situations, the second sample here did make the prediction worse. And in other models, the prediction got better. So it was not that clear-cut in the data sets and across different models that we looked at. What was certainly very interesting is that here you see the time after TDM, so the age of the TDM sample and the prediction error. And you can see the older the TDM sample, the higher the prediction error. So there is certainly some information in that, which means the more recent the sample is, the more accurate the prediction actually will be. So here are some take homes for unstable patients, and that's also what we did in our workshops when we train clinical pharmacists to deal with that phenomenon. So it could look like this, that your TDM data is not properly fit and deteriorates from the model prediction. So here you are too high, here you are exactly on spot, here you are too low with your model prediction. So that's a case where you probably see some deterioration. So you first should make sure whether there's a time varying covariate that is maybe not considered, maybe a change in renal function. Should also always check if another model that is embedded in your software maybe can describe your patient at hand better. And then if that also doesn't work, you could consider removing older data as was done here. So I'm flipping back and forth. So these old samples, they actually did not improve the prediction, so we only kept the most recent one. Or some software packages also have weighing functions that weigh down old data, which would be also something to look into. Okay, I want to conclude here. So I hope I could show you that dosing software such as TDMx can help to streamline dosing suggestions, can be used to calculate a first effective dose. Don't need to wait for steady state. Any samples can be used, but certainly some samples are more informative than others. And I think this is also a nice area where we could do research at the intersection between, pharmacometric research and clinical practice to look more into algorithms, for example, to improve instable patients, to look more into sampling schemes. And also that last point that was already highlighted by our first speaker, we need clinical trials also looking into the benefit of using such approaches. Yeah, thank you for your attention. Just want to acknowledge my research group, our funders, and also the collaboration partners here, Sophie Stocker, Peter de Kock, Ken Klinker, and Uwe Liebchen, with whom we did these external evaluation studies that I showed today.
Thanks so much, Sebastian. That was very informative. Some of the things that you've come up with as far as the model averaging technique is very, very novel in its use, and I look forward to maybe having some questions from some of the viewers who might want to follow up with some comments as well. In the interest of time, if you're happy to hang on, Sebastian, till the end.
Yes, I'll be around.
That's great, because we may have some questions for you.